This is the 92nd edition of the Psychcast. I'm the voice of MD Edge Podcasts, Nick Andrews. Before we get going on this episode, I'd like to invite you to take part in our listener survey to help make the Psychcast a little better. So if you have thoughts on how we can improve, please follow the link in the show notes. Coming up later, a masterclass lecture from Dr. Martha Sajatovic of Case Western Reserve University School of Medicine in Cleveland, Ohio. The topic this week is older age bipolar. Before we get to This Week in Psychiatry, I wanted to mention something that we're doing at MD Edge Podcasts in an effort to make Psychcast and all of our shows a little better. We have a simple listener survey in the podcast notes. If you wouldn't mind, take a moment and fill out the questions. The survey is, of course, anonymous. It's time now for This Week in Psychiatry. This Week in Psychiatry, the ACGME is deepening its commitment to physician well-being. Dr. Timothy Brigham is the Chief of Staff and the Chief of Education and Organizational Development Officer at the Chicago-based Accreditation Council for Graduate Medical Education, or the ACGME. He spoke at the 2019 annual meeting of the American Academy of Pediatrics in New Orleans. Dr. Brigham said that when he thinks about the impact of burnout and stress on the ability of doctors to practice medicine, he thinks of Lewin's equation. Lewin's equation holds that behavior stems from a person's personality and the environment that he or she inhabits. He said that we suspect that between 70 and 80% of the problem with burnout and stress in medicine is environmental. It's a toxic mind, he says. He also said that when we detect that physicians or a residency program is burnt out, we recommend resilience training. That's not unimportant, he says, but it's like putting a canary in a toxic mine and saying that you're going to teach you how to best hold your breath. The best approach is actually to detoxify the mind. Troubled by the rise of suicides among physicians in recent years, as well as mounting evidence about the adverse impact of burnout and stress on the practice of medicine, Dr. Brigham said that the ACGME is deepening its commitment to the well-being of faculty, residents, patients, and all members of the healthcare community. Since launching a call to arms on the topic at its annual education conference back in 2015, the ACGME has added courses on well-being to its annual meeting and remolded its clinical learning environmental review program to include clinicians because everybody is affected by this: nurses, coordinators, etc., etc. The ACGME has also revised common program requirements, disseminated tools and resources to promote well-being and new knowledge on the topic, and partnered with the National Academy of Medicine Action Collaborative on Clinician Well-being and Resilience, all in an effort to bring about culture change. But Dr. Brigham also said that he is well aware that the ACGME cannot do it alone. He continued by saying it's going to take a culture shift. Only you, the physicians, he says, in collaboration with everyone in our community of learning, can create the systemic change required to improve our culture. And that concludes This Week in Psychiatry. You can read news just like that and more at mdedge.com/psychiatry, and you can read this story in full by following the link in the show notes. When we come back, it's time for our masterclass lecture with Dr. Sajatovic.
My name is Dr. Martha Sajatovic. I'm a professor of psychiatry and of neurology at the Case Western Reserve University School of Medicine in Cleveland, Ohio. I also direct the Neurological and Behavioral Outcomes Center at University Hospitals of Cleveland. I have been doing research in older age bipolar disorder for a number of years now. I am delighted to see that it is a topic that has gained increasing attention and awareness among clinicians and researchers in our field, and that's a very good thing. What I want to talk about a little bit today is bipolar depression in later life. In the past, we have often tacked this topic onto kind of a bin or an umbrella term of special populations. And in fact, there was really very little research in this topic. We often just extrapolated findings from larger clinical trials, and there was not much focused attention. So that is changing slowly, although it's still not ideal. What I believe is driving this trend, this pattern of greater awareness is simply demographics. We know that the number of older people is increasing substantially, both in highly developed countries as well across the globe. For example, the number of people who are age 60 and older has doubled since 1980, and the number of people aged 80 and over will increase fourfold to almost 400 million by the year 2050. As a matter of fact, by 2020, so next year, adults age 65 and older will outnumber children under the age of 5. So this is a really major demographic milestone, first time in the history of the world, where we're really seeing that fulcrum, the tipping over where elderly are overrepresenting our population. So our healthcare system, unfortunately, isn't really geared toward that. What needs to happen is greater awareness and more research, specifically focusing on older adults who have different needs from mixed-age adults. Shifting gears a little bit and talking about older age bipolar disorder, or OABD, it is defined as people over the age of 60 or older. It makes up about a quarter of bipolar patients if you look at clinical samples. This is a population that's very heterogeneous. We often separate them into early versus late onset. While there's no official consensus as to what constitutes late onset, most of the literature suggests that if you have your first manic or hypomanic episode at or after the age of 50, we might consider you to be late onset bipolar disorder. We see that there are some differences in the way people present clinically when they're older versus younger and having bipolar disorder. Manic episodes might be a little attenuated. That's not uncommon. Unfortunately, the depressive episodes tend to be pervasive, enduring, and cause substantial impairment. One of the biggest issues that we deal with in older age bipolar disorder, and the literature uses the acronym OABD, you may see that in various publications. But the big deal in OABD is that people tend to have more medical comorbidity. It's not unusual, and in fact it is the norm for people to have 3 to 4 significant medical comorbidities. So we might see cardiovascular disease, diabetes, thyroid abnormalities. And in fact, the risk of mortality in people with bipolar disorder prematurely is much higher than the average population. Data is out there that suggests that folks with bipolar disorder lose 1 to 2 decades of life compared to the general population. So it's really significant. Many of you listening are clinicians. Clinicians always want to know, how do I help people? What do I treat people? We have limited data. There's not a lot out there. There are certainly selected agents, medication treatments that are approved for bipolar disorder. To get back to my topic of bipolar depression, there's actually very few. We only have 4 agents that are FDA approved, and they are all, at least in some component, second-generation antipsychotic drugs. There are many more drugs that are FDA approved for bipolar mania, and a fair number for longer-term treatment of bipolar disorder as well. I think the point that's worth mentioning is that there are no drugs that are specifically approved for older age bipolar disorder. So that is not a classification that the FDA has given at this point. I've been fortunate to participate in an international task force that was convened by the International Society for Bipolar Disorders, specifically focusing on OABD. And a sort of interesting exercise that we did a few years ago was to look at what the international guidelines say about the treatment of OABD. Very interesting. We found somewhat disappointingly that the guidelines didn't really have separate sections for OABD. We looked at 35 guidelines from 6 continents and 19 countries. They were published from 2005 to 2015. The general principles were similar to younger adults with bipolar disorder, whether it's bipolar depression or bipolar mania. Probably the best rule of thumb, and this is the mantra of geropsychiatry, but it's a good rule to follow when you're treating older people with bipolar disorder, is whatever you pick to start with is to start low, maybe half or even less than you might in a mixed-age young adult, and then titrate more slowly. And one way to think about it is generally, bipolar disorder is a chronic health condition. People that you see who are older will have often or typically lived with bipolar disorder for a long time, and it makes no sense to jump on them like a ton of bricks and make dramatic changes in medications, hitting them with heavy dosing, or even dosing that we think of as standard with younger adults. Take your time, allow people to become tolerant to any side effects. Those are often transient. You're really going for long-term outcomes and improving their quality of life. In bipolar depression, we do not have specific treatments that are FDA approved for older age bipolar disorder. The Canadian guidelines and the ISBD guidelines, as well as a recent task force Delphi survey, suggests that first-line treatments will include quetiapine or lurasidone monotherapy. Lithium is, especially in the recommendation of the OABD task force, an underutilized drug. We don't use it enough and appropriately in bipolar disorder generally, and that may be particularly true for older adults. Again, thinking about your dosing and slow titration is particularly important. One issue that has come up in the OABD research community is if we use lithium in an older adult, what is the most appropriate dosing or therapeutic target with respect to serum levels? Many laboratories will give a reference range of 0.8 to 1.2 milliequivalents per liter for lithium. Then the task force is pretty clear that that is probably too high for almost all older adults with bipolar disorder. In fact, a more appropriate target with respect to what you're shooting for on a blood level might be in the order of 0.4 to 0.8 milliequivalents per liter, especially in people who are older or more frail, where you might actually look at really going toward that lower end of the spectrum. There's been some research on drug treatments in OABD. I mentioned the Delphi exercise with the lithium level. Our team a number of years ago participated in a collaborative study using lamotrigine in older age bipolar depression. We found that generally it was helpful and fairly well tolerated. That was not a controlled study. There's been some post hoc analyses with quetiapine, and our team has also recently published a post hoc analysis with lurasidone, looking at the pivotal FDA trials data and examining a subset of older patients age 55 and older, and found significant improvement with monotherapy with lurasidone compared to placebo in people age 55 and older, again with reasonable tolerability. So those are drug treatments. Just as with mixed age populations, we find that behavioral treatments can be very helpful. An additional point that I'd like to make in terms of managing the older person with bipolar disorder is we need to be attentive to comorbidity and psychosocial support. So you remember I mentioned that people might have an average of 3 to 4 significant medical conditions. If those are not supported and managed appropriately, it will almost always make the bipolar disorder worse. So that integrated care, working with primary care or specialty care clinicians in a holistic way to address all health conditions is really key. Thank you.